Good morning and welcome to CARB's Research Division Seminar Series. My name is Cynthia Garcia and I'm the Contract Manager. First, I would like to go through some housekeeping rules. Should there be an emergency, please exit the doors marked with the exit sign and walk down the stairs to the Cesar Chavez Park. For those of you who are attending via the web, you will be able to see the presentations on our seminar web pages. You will also find on the screen the email to send your questions. Questions will be answered at the end of the presentation. Now, I would like to provide a brief introduction on today's seminar on Integrated Transport and Health Impacts Model, normally known, or commonly known, I guess, as ITHIM. CARB funded this project to elucidate the benefits of active transport. As you all know, a car-centric transportation system is associated with long and sedentary commuting, noise, air pollution, urban sprawl, community division, and traffic injuries. Active travel, such as biking and walking for transportation, is associated with improved public health through increasing physical activity and decreasing air pollution. Low levels of physical activity contribute to premature deaths and rise the risk and cost of major chronic illnesses. About 20% of Californians indicate low to no physical activity. In addition, the transportation sector accounts for about 40% of directly emitted greenhouse gases annually. Therefore, CARB's research supports tools to improve health, publicly accessible tools such as the Integrated Transport and Health Impact Model, which can be used and applied to help convey health benefits of a shift from cars to active physical transportation, demonstrate how active transportation can increase the health of our communities, provide a measure of sustainable community strategy goals, inform clean transportation options in meeting air quality standards, measure the impacts of cleaner and healthier transportation options. I would now like to introduce today's speaker, Dr. Neil Maislish. Dr. Neil Maislish is an epidemiologist with over 30 years of experience in research methods, statistics, and health in government, academia, unions, and healthcare organizations. He currently is a visiting researcher at the University of California, Davis, where he models the health co-benefits of active transport as a greenhouse gas mitigation strategy. He is also a senior researcher scientist at the Public Health Institute, focusing on the development of the healthy community indicators. And now I would like to turn over the presentation to Dr. Neil Maislish. Thank you.
Hi, I'm Neil Maislish, and it's a pleasure to be here. This is actually the culmination of 16 months of work on a contract with the Air Resources Board. And before I acknowledged all the people who worked on the project, I just wanted to provide a little bit of background and context to the project and amplify some of the comments that Cynthia provided. And then I'll go into the details of the project. So what is the problem that we're trying to solve? Well, I think everyone has heard this, and I'll say this emphatically again, that climate change is the primary existential threat to public health for California, for the United States, and for the world. This is really, I can't say this more emphatically. In California, transportation is the largest source of greenhouse gas emissions. Of the roughly 425 million metric tons per year, about 40% of that comes from the transportation sector. So that is a big piece of the puzzle. If California were its own country, and I suspect there's some people who would like that to happen sooner than later, we would rank in the top 20 countries of emissions. So we, even though we're doing a lot of great work on the policy front on this topic, we still emit a lot of carbon into the atmosphere. So given that the transportation system accounts for a good chunk of the carbon emissions, how we can reduce those emissions is the key question. And of course, we can focus on increasing the efficiency of vehicles and their fuels, whether we electrify them, use low carbon fuels, that sort of thing. We can reduce vehicle miles traveled, and there's a number of ways to do that. We can, rather than go solo, as many of us do on our way to work or other places, we can double up, carpool, things like that. Or we can look at active transportation or mass transit as ways to reduce vehicle miles as well. So there's a number of different strategies that we could pursue. The question is, which ones would actually yield health co-benefits or other kinds of benefits, whether they're economic or environmental? And I think it's been said many times that smart strategies solve multiple problems. So on one hand, we have our challenges with greenhouse gas emissions and climate change. On the other hand, we have just sort of what goes on every day in California, which is a chronic disease epidemic. Something on the order of 93% of the burden of disease in California is really about chronic diseases or non-communicable diseases. That we could pursue solutions to those two major public health challenges. We could pursue them in isolation, or we could identify where there are linkages and see if we can actually solve multiple problems with the same kinds of strategies. So the question then becomes, so what are the strategies that would generate these health benefits? Would they have untoward consequences? We have to be aware of that. Which strategies generate the most health benefits? Which ones generate the least health benefits? And how do we even begin to measure that? So these are the questions that we are posed in the development of the ITHIM model. And right now, I'm just going to give a sort of just a very high-level overview of the model. I know we have somewhat of a mixed audience, so I'm not going to get so technical to make it possible for a lot of the audience to understand. But with this bubble diagram, I'm just illustrating the major health pathways that the transportation system impacts human health. We're talking about physical activity, and that's largely through human-powered effort, bicycling, walking, scooters, all kinds of other kinds of human-powered devices that are now hitting the road, traffic injuries, and air pollution, obviously through tailpipe emissions and other sources of emissions in transportation fuels. We use many different data sources. Many of them are public and really important. So in order to model physical activity, we use information in the California Household Travel Survey. We use information in the California Health Interview Survey for identifying travel patterns. We also use the outputs of the regional transportation planning organizations or metropolitan planning organizations, MPOs. We use the output of their models. We also use information on traffic injuries from the statewide integrated traffic record system, or SWITRS. We also use a modeling effort for air pollution from resources that the Air Resources Board has provided through the MFAC modeling, or the MFAC model, which models car emissions, among other things. And we also use data on vital statistics and a number of other sources. So what ITHIM actually does is it takes these huge public investments in data and integrates them in a way that predicts, based on changes in travel behavior, changes in health status of the whole population. So what do we mean by that? We're talking about premature deaths. We're talking about disability and years of life lost, which are combined in a measure called disability adjusted life years. We can monetize those outcomes so that we can have some idea of what the financial implications of the strategies are, as well as modeling carbon emissions. So the model has all of those outputs. So just a brief explanation at a pretty high level of how the model itself works. So you can most simply think of this in terms of that there will be changes in the population disease rate and injury rate in response to mode shifts in vehicle miles traveled, or actually miles traveled of a number of different modes. It's biking, it's walking, it's bus, it's rail, it's car, it's truck, it has all those different modes. So with physical activity, we're really talking about the change in the distribution of physical activity time in transportation. I think people have some sense of what this distribution looks like because, as Cynthia mentioned, we're a pretty car-centric society, and we largely do not do a lot of physical activity in our transportation system. So there's a lot of people who basically do little or no physical activity. And then there are other people who are out there riding their bicycles or walking many minutes a day. So this distribution, we call it a log normal distribution, but the whole idea about active transportation and promoting active transportation is shifting that distribution so a higher percentage of the population is getting higher levels of physical activity. Most people have an understanding that with increases in physical activity, you actually reduce your disease risks for a number of different chronic diseases that I'll mention in a couple of slides. So, what are the other health implications of shifts in VMT by mode? Well, fine particulate matter will also be impacted. So if we are lowering car miles travel, we're also lowering the emissions. And that means that on a basin-wide effort, that those tailpipe emissions are not going to be interacting with the rest of the constituents out there and creating the background air pollution levels that we experience. We also have to recognize that there's concern that some people who might be biking or walking near busy highways could get enhanced exposures because they're huffing and puffing and having a much higher ventilation rate. Their inhaled dose could actually be a little bit higher than if they were just sitting in a car, although I should point out that sitting in a car behind another car in traffic is not so safe either. Okay, as far as road traffic injuries, this is interesting because injury rates on the road are related to the distances that are traveled, the speed and volume of all the different actors. And it does take two to tango, pretty much. So that's one feature of the model, which is actually somewhat novel and somewhat more accurate than many other kinds of ways of looking at injuries in transportation, because it takes into account the travel behaviors of both the striking vehicle as well as the victim vehicle, and the victim or mode of conveyance, because it could be a collision between a pedestrian, who's the victim, and a car. So all the different modes can interact, and that's something that the model takes into account. There's some very interesting things that one can predict, and actually with the recent report from, I think it was the Federal Highway Administration about just the national profile of traffic injuries, where we saw an overall decrease in injuries, but an increase in pedestrian and bicyclist injuries, actually a pretty significant increase. So these things are not mutually exclusive. There are tensions in the transportation system and potential conflicts where you can have situations where car-to-car collisions decrease, but car-to-ped, car-to-bicyclist actually increase. And it's really interesting because this phenomenon actually was predicted by ITHIM several years ago, before all these studies were emitted. So it's actually kind of interesting to see that, in a sense, the validation of the model by just what has happened in the last few years with the post-recession recovery seems to be consistent. I should also just point out that the model does include this concept called safety in numbers. And it just is an observation, an empirical observation, that as mode share shifts to more bicycling and pedestrians, the injury rates to pedestrians and cyclists tend to decrease in an exponential manner. So that's actually an important feature, and it makes the model feel more realistic as well. Let me just talk a little bit about the monetization of the health costs. So we use two different approaches. One is one that's fairly used in regulatory circumstances. It's called the value of a statistical life, or the willingness to pay method. And it fixes a dollar amount on a life, whether it's $9.8 million, which is currently being used by US EPA, or some other large figure. And it just multiplies that by the number of deaths that would be averted if, in fact, the transportation system had more active transportation. The other method is more conservative, and it goes about adding up all the medical bills for diagnosis and treatment, but also measures lost productivity. Because if you die before your optimum life expectancy, there's a certain number of years where you could have been working and earning income. That productivity loss is actually what's being measured. All these things are scaled to the California population, and the change in the morbidity and mortality is what's being multiplied, the percent change due to the change in the distribution of, again, road traffic injuries, or actually distances related to road traffic injuries, the air pollution benefit from having less car travel, as well as increased physical activity. As far as carbon emissions, we model it in a very simple way by just taking the change in car VMT and multiplying it by the emissions factor and the population. So we're able to predictions about how carbon emissions change with changing scenarios in travel. So I want to just quickly talk about and reemphasize what the public health connection is of the modeling effort. As I mentioned, for physical activity, these are the specific diseases that are modeled. Heart disease, which includes ischemic heart disease, popularly known as heart attacks, but also in there is hypertensive heart disease, stroke, diabetes, dementia, which includes Alzheimer's disease, but other dementias as well, major depression, colon cancer, and breast cancer. And I just wanted to point out that some of the endpoints are poorly reflected by just looking at deaths. And that's why this measure of disability-adjusted life years, which also takes into account years living with disability, is so important. When you look at vital statistics, you'll see that deaths due to depression are not particularly high in California. But we know that a very large percentage of the population is impacted by mental health issues. So by using this disability-adjusted life year approach, we actually are sort of leveling the playing field so that these non-fatal but highly morbid conditions get represented in the burden of disease. So when I talk about the burden of disease, I'm talking about both mortality as well as morbidity, being ill for a certain period of time. Air pollution shares several of the health outcomes, the cardiovascular outcomes, with physical activity. So they actually coincide. But in addition, there are a number of respiratory conditions that are unique to air pollution, as well as respiratory diseases in children. Road traffic injuries, that is pretty much what is occurring on public roads. The model stratifies this by roadway type, meaning a local road, an arterial, or a highway. And those are actually surrogates for speed and volume, so that we can correct for that. There's a lot of change in highway travel by cars. There's hardly any pedestrians and cyclists out on highways. So we want to make sure that where the interventions are occurring and where the conflicts are occurring are adequately or accurately predicted in the model. So that's why we stratify by that, because most of the collisions between cars and pedestrians and other vehicles and pedestrians and bicyclists are occurring on local roads and arterials, not on highways. Okay, again, I just wanted to re-emphasize the importance of the endpoints of the model and the chronic diseases that are besetting California. Again, my introductory comment was greenhouse gases on one side, chronic diseases on the other side. So here's the relevance, because the ITHIM model actually takes a shot at the major leading causes of disease and death in California. So this is just a ranking from 2017 of the leading causes of death in California, and you can see that heart disease tops the list, and of course those ischemic heart disease, hypertensive heart disease are components of heart disease. Cancer, not all cancers are modeled in ITHIM, but breast cancer and colon cancer are. Stroke is modeled. Alzheimer's disease, chronic lower respiratory disease, that's an air pollution endpoint in the model. Unintentional injury, that combines both injuries that are occurring by road traffic, but it's also other kinds of things that are not suicide. Could be unintentional drug overdoses. So I want to take credit for the entire category, but a big chunk of that is, in fact, motor vehicle collisions. And then diabetes. So this just re-emphasizes that the modeling that we are doing in ITHIM is really touching upon the major public health conditions of California. Before I transition into talking about our project per se, which is really kind of geeky and is going to talk about how we develop software, I just wanted to point out that the ITHIM model is now being used in a number of locations within California and other states around the country, and it's gratifying to me, because they're sort of like my children in a sense. I've been promoting the model and helping people implement it around the United States. And for the major MPOs in California, each one of them now has had an implementation, almost all, except for SCAG. But SCAG has been trained in using the model, but the MTC, Fresno COG, SANDAG, SACOG, they've all had some kind of implementation of ITHIM in their setting. The California Department of Public Health, the Air Resources Board, now are behind the effort to make the model available and implement it in a much easier platform, which I'll get into. But the state of Oregon has been running the ITHIM model for several years now. Basically, once a year, they do an update and they run the model. I've helped implementations, the University of Maryland at their National Center for Smart Growth. So they've implemented it there. They're now interested in looking at counties within Maryland. Delaware has an implementation. Massachusetts has calibrated the model, but they haven't gotten the money yet to run scenarios. And Vermont is the most recent state to implement the ITHIM model, and they just finished that little project. We have a number of other kinds of implementations, not at the state level, but at the local level, that are really important to acknowledge. So Nashville, Tennessee has implemented ITHIM several years ago, and with the assistance of staff at the Centers for Disease Control. And our Los Angeles County Health Department has implemented ITHIM pretty much on their own as well, looking at the mobility plan for the city of LA, the Mobility Plan 2035. So there's a number of different organizations, health departments in conjunction with transportation departments, academic researchers have all implemented the ITHIM model. I should also point out that UC Davis is a research hub for the ITHIM model, as well as the University of Wisconsin. And folks who were previously at the University of California at Davis are now at University of Texas in Austin, who are also applying and developing more advanced versions of the ITHIM model. So this is just a snapshot of what's happening in the US. There's actually an international developers group led by James Woodcock at the University of Cambridge in the UK. But there are implementations going on in New Zealand and Australia and in Brazil and India and a number of other locations. So the model is slowly, and I should point out that there is no budget for marketing and there is no budget for really promotion. So it's pretty much been a pretty loose network of people who are committed to this kind of research that have been keeping the model going. And now with the Air Resources Board, it's been really important. have a platform and a lot more visibility and stability to those efforts. So let me now segue into a description of what our project is. So this is a roughly a 16-month project that was aimed at taking the spreadsheet version of ITHIM. That was the original version. It was a very low-cost version, and it was based on aggregate data. And it was really unwieldy. It was something like 40 different worksheets in one big workbook. It wasn't particularly user-friendly. It was highly functional, but it wasn't all that easy to use. So that's really what we wanted to have our starting point, and move that with all its functionality into an open source, web accessible platform. Okay, we wanted it to be easy to access and use by state agency scientists, policy analysts, planners at the state, regional, and local level, academics, and community-based organizations. So that was really what we wanted to do. We wanted this to be easily maintained by Air Resources Board staff. And to get a little bit more detail into what exactly was the scope of our work, we wanted to, one, create a data repository of the calibration data at different geographies, county, region, and for the entire state. We wanted to translate that existing functionality, which are buried in thousands of Excel formula, into the R programming language. So I should just point out that R is an open source, free statistical processing program. It is now sort of taking on like wildfire in a lot of academic settings. It has a whole community of people who write special programs to support it. And it is what is pretty much in the pipeline in a lot of academic institutions. The students are using R, and now when they graduate, they expect to be in a workplace that uses R. So that's good from the standpoint of maintenance and continuity, that there are people in the pipeline who do R programming and could support the program. The application itself, we wanted it to be easy to use and have a nice interface so that the user could manipulate things. They could select canned or built-in scenarios. They could upload data that would be their own scenarios. We wanted them to generate outputs that were familiar, tables, graphs, other kinds of things that you'll see in a second. We also didn't want to just put out a bunch of tables with numbers. We also wanted to provide, sort of wrap it around with information that helps contextualize the outputs. Because the people who would be using this aren't all going to be public health people. They may be coming through the transportation door and may not be as familiar with the health outcomes and the vocabulary. So we needed to provide information so that they would feel that they could access the information and communicate it within their organization or to other people that they have to work with. And also, we wanted to provide evidence-based strategies so that once you generated output, next question is, how do I get there? What are the infrastructure? What is the engineering? What is the encouragement? What are the incentives? What are the strategies that can help get that level of health benefit? So we wanted to provide that information as well. Okay. The other pieces of the scope of work is that the earlier spreadsheet versions only had air pollution data for the Bay Area. That's because in the origin of the project, back when I was working for the California Department of Public Health, we had the Bay Area Air Quality Management District help us with airshed modeling, which is a very complicated way of predicting how the ambient or the breathing zone air would be impacted by changes in car travel. So they used very sophisticated models to do that. It was difficult for that to be reproduced elsewhere. So our scope of work was to work with the Air Resources Board in incorporating air pollution data in the way that they do, that we could have a statewide coverage for air pollution. Okay? The other parts of the scope of work is really document this R version. There is a package within R which creates the kind of language that the web recognizes. It's hypertext markup language, HTML. So using the R program with this Shiny package enables researchers like myself to create beautifully looking websites. And it's just an amazing feature. So that's how we created the website that you'll see shortly. The other pieces of this is to provide, again, support information for users and the ARB staff so that they could use the tool with a relatively low threshold of knowledge. I don't want to pretend that that this has been de-skilled to the point where anyone without any background in health or transportation or planning could just waltz in and use the model and understand every little aspect of it. But as you'll see, we've layered levels of detail so that depending on what your entry point is, you'll find something, some output that will match your skill sets and ability to communicate to your constituency. So this is the point where I want to just explain how the project was organized, but it also gives me an opportunity to acknowledge some of my co-collaborators in this, because I didn't do this all by myself. I had a whole team, and it really was a dream team of folks, starting with actually Cynthia at the Air Resources Board, who was the contract manager, and also Barbara Weller also assisted in that effort as well. So we had a very great working relationship in which ARB staff were really incorporated into virtually every aspect of the project. This was done by the University of California at Davis. Jonathan London is a co-PI on the project along with me. He's in the Department of Human Ecology and also the director for the Center for Regional Change at UC Davis. He was part of the project as well. So you can see on the diagram that we basically have a central axis and a left side and a right side. So the left side is really about user liaison. You can't develop software without users being intimately involved from the beginning to the very end. So Jonathan London, Carolyn Rodier at UC Davis, and Linda Rudolph at the Public Health Institute helped with identifying people who would be potential members of a users group, and then helping and sort of behind the scenes help me sort of work with the users. On the technical side, we were able to hire a graduate student, Kenji Tamari, who was with us for the entire project, and several other people as consultants. We had a real live software engineer, CJ Jiang, who's at the University of Maryland, and also a website designer, Amy Weir. We also had some extra funding through the Nicholas Linish Legacy Fund, so we could hire another part-time graduate student, Sarah Grajdura. So this, to me, was the dream team. I've been developing software on and off for the last 20 years, and I've generally done it in an environment where I didn't have all the pieces there, where you have someone who can really deal with the back-end stuff, like a real live software engineer who knows about server structure and all the performance issues on the technical end, working with Amy Weir, who's a graphic designer and who's worked with me previously at this, and worked with many people at the California Department of Public Health. It's great to have people who really have a great design sense to work with you, rather than me dreaming up what the designs should be. And I really lucked out with the graduate students. They were just really talented. Kenji Tamari is a spectacular R programmer and just a really nice guy. So we really had a dream team to pull this off. I'm going to talk a little bit about the users group, because the users group was really, without it, it would not be the product it is now. It was really their input. And the strategy is to engage people who previously had some connection to ITHIM. either because they were state agencies that helped develop it, or they were consumers of the information. They could have been advocates using the outputs of ITHIM for their advocacy or education work. The group was comprised of 43 representatives from 27 different organizations. So it's a pretty large group. I'll show you, we had 4 quarterly meetings each time to discuss a prototype of what the website would look like, and initially to just get feedback on what were the concerns they had and what interests they had that they wanted to see reflected in the website. The participants spanned local and state and regional government. So we had participants from the metropolitan planning organizations who I'd worked with previously who had installed the spreadsheet version. So this now is going to be something that hopefully made their lives a lot easier as well. We had transportation and health agencies, so California Department of Transportation, as well as the California Department of Public Health sent multiple representatives to our meetings. We had a number of nonprofit organizations that were community-based, and they spanned environmental justice, climate concerns, health organizations, as well as advocates for bicycling and walking. Because we had concerns that some of the smallest MPOs might not be able to use the model, we wanted just to explore with them in a separate dialogue what their interests were, what their barriers were to using the model. So that was also part of the engagement with the community. So on the next slide, of course, no one can read this except me, but the point is that these are the 27 organizations that participated. You can see just from members of the audience with the air quality management districts from Sacramento, from the Bay Area as just one element, as well as the Air Resources Board. We had participation from local government commission that represents advocacy and education for local governments, as well as local health departments from San Francisco, from Sacramento, and from Los Angeles. So these are just examples of the kinds of organizations, many different advocacy organizations as well. So they reflected both technical as well as policy orientation. So again, that was part of the strategy, is initially have these conversations where the policy people could be in one group and the technical people can be in a separate group, because when you often mix them initially, the vocabulary and it descends into sort of a geeky conversation that alienates someone or someone else. So the point is that we started apart, but then after the first meeting or so, we combined the groups because they were looking at the same prototypes, making the comments on all of the different aspects of it. So this is really just a shout out to all the representatives and all the organizations that participated over the course of the year. And because without their input, this website would have looked very different. Okay, so I'm going to talk a little bit about the data sources that we used. I should just point out to begin with that all the data were aggregated. There was no individual level or personal data that was handled. So this was already public data. As far as the travel and travel-related physical activity, as I mentioned previously, the California Household Travel Survey played a big role in the travel patterns for all the different modes. The statewide and regional travel demand models were also used, some of the outputs for some of the modes that weren't covered by the travel survey, so truck and things like that, and sometimes bus modes. The California Household Interview Survey was also used well for emissions. We used the MFAC model, and we used the incidence per ton method for characterizing how emissions impacts mortality as part of, and that was something that Jeff Austin from the Air Resources Board really helped, along with Alvaro Alvarado and a whole team of folks who really helped me with that part of the model. Health outcomes come from the Global Burden of Disease Project from the Institute for Health Metrics and Evaluation. It's part of the University of Washington. and, as I mentioned, the Switters data. And that was also an improvement that we did in the model. The earlier versions, the spreadsheet versions, had much older data, pre-recession from 2006 to 2010, but we updated that with more recent data from 2011 to 2015, which really reflects more of what the current travel environment is rather than the pre-recession or recession environment. And then we leveraged population projections from the California Department of Finance. So one feature of the model is that it can project the burden of disease out into the future. That's pretty much how long-term regional planning in the transportation arena works. The sustainable community strategies or the regional transportation plans, although they're updated every 4 years, they're talking about a time horizon that spans 20, 25 years. So when they develop their plans, they often have dates like 2035, 2040, 2045, 2050. So able to make the time horizon relevant to those transportation planners, I had to incorporate population projections, as well as projections at what the disease rates were going to look like into the future. And because that is a topic that is of great interest to our federal government, because Social Security benefits and Medicare benefits and other things are very much dependent on the mortality patterns of the United States, there are a number of researchers that provide estimates of what the annual percent change in mortality by disease is or is expected to be. So I incorporated that so that all the inputs and outputs can align to a year that a user selects. So if they want to project it just what it is for today, they can do that. If they could instantaneously create the infrastructure changes and all the policy changes to achieve the change distribution in walking and biking, and that they could do it instantaneously, though they can pick 2019 as their year of reference. Or if they're interested to look at it, what's going to be in 2040, they can do that with the recognition that the California population is going to be aging over that period of time. A much larger percentage of the population is going to be in the older age categories, and that obviously has implications for what the burden of disease is going to be. So here's a complicated diagram of inputs and outputs. You see a lot of blue boxes. That's about all you can see. Each one of those represents a particular data input. So I've organized them for the purposes of this as travel, physical activity, PM 2.5, road traffic injuries, and health outcomes. So there's a number of files that are inputs. This is really the calibration data that we're talking about. The yellow boxes represent just constants that are used in the model. And then the lighter gray is really, which is surrounded at the very bottom of the diagram, surrounded by dashed lines, is what we call the analytic engine. So that's where all the calculations are done, and that's where the methodology, which is called the comparative risk assessment methodology, is actually implemented. That analytic engine then puts out outputs, as I mentioned previously. So this is sort of just a high-level diagram of the inputs and outputs of the model, and the challenges are how do you develop the analytic engine? How do you develop an interface where all this stuff behind the scenes is not going to be very apparent, but how do you make an interface that's engaging and informative for users? So a lot of our project was about that. Part of our scope of work was to create a data repository. So there's roughly 24 data files that have this calibration data. We had to do a few new analyses. As I pointed out, we didn't have complete information on air pollution before the project. Now we do, so that had to be analyzed, and a couple other things that I've already mentioned. I should also point out that as an extension of the contract, there was time to actually do race ethnicity files. So this is something that basically announcing publicly for the first time, but I took the California Household Travel Survey, and with the information that was available in several fields, was able to pretty much create a nearly complete data for major race ethnic groups. So those are white, black, Asian, and Latino. recognizing that there are other groups out there, but the problem was that there wasn't statistically reliable data, nor could I maintain a symmetry of all those different groups throughout the health outcomes as well, because I had to get comparable health files, which I did through adjusting the burden of disease by mortality data that was available through the Centers for Disease Control. And they only provided in these large groups. So that, I acknowledge that as a limitation, but I think it's an advancement on the issues of equity that people will be able to analyze the whites, the blacks, the Latinos, and see how the scenarios could differentially impact those different populations. And those analyses are available at the state level and at some of the regions that have large population centers. At the smaller MPOs, I don't believe after you break up the California Household Travel Survey data into age, sex, and other small, mode cells, we basically run out of sample size. So we have a bigger sample. I think we're going to have to live with those limitations. Okay, so now I'm going to talk a little bit about the R-Shiny interface of the model. So we coordinated with the Air Resources Board staff. We wanted it to have a kind of look and feel that the current website has, so that it doesn't look totally disconnected from other work that the Air Resources Board does. They were very cordial in sharing their photo library with us. So a lot of the photographs that you see in the website are actually from their photo library. The other piece of this is that it's something I've been aware of for quite some time, but there's now state legislation requiring state agencies to make sure that their websites are accessible to all users, including those who may have visual impairments or mobility impairments, who might not be able to use a mouse. So that was something that early on in the project we discussed with the communications office at ARB, and was able, fortunately, the R-Shiny platform follows a lot of the conventions of the accessibility guidelines. Nonetheless, we had our web designer who was attuned to these issues, because a lot of solving the accessibility issues is just about good design. So she helped us measurably to incorporate those good design principles into our website so that the website would meet accessibility standards. We also did a lot of research on other kinds of websites before we started the project, looking at everything from this is not a paid announcement, but like Nike and Amazon and all the commercial shopping places to see how they designed their website, as well as went to a lot of NOAA and other scientific organizations to see how they presented data. The idea was to gather information the idea is to create a website that looked quote unquote normal, so that the threshold for people accessing the website would be very, very easy, so they wouldn't have to learn some kind of novel interface to learn how to use the website. The other thing that I think was really important from our users group was the idea that it's not just tables and graphs, that we need other ways of communicating the results. So an important thing emerged early on, that we needed a kind of elevator pitch. That's what people called it, like a bullet point with it's highly graphic that would just be a short summary of what the main findings are. So that was an important feature. And also, there were folks who were very interested in how we might be able to create an interactive infographic, which, again, wasn't part of the original spreadsheet version, but it's certainly something that people are very attuned to these days, of telling a story, scrolling down through a website to sort of communicate the information. So these are things that were incorporated with sometimes a fair amount of effort on our part to try to program this stuff. Okay, so the process, it's a lot about prototyping, starting from wireframes or PDFs, and then trying to imitate them using the R and Shiny programming language. So this is if you're old enough to remember the commercials, is it real or is it Memorex? Here's on the left side is what the PDF looks like, and on the right side, that's a little bit of the R Shiny programmed version that's been put through a web browser, and you can see that they're pretty darn close. So that was the idea, is to go through these iterations of showing the users group members what we thought they would like, and then getting feedback on what they liked and what they didn't like, and then we just did several iterations to get to a beta version, actually first an alpha version, then a beta version, and then refinements from there. The analytic engine came from prior work. We polled folks who've been doing this kind of work at the University of Wisconsin, some work that I had done prior to the project, and also what had been done in SACOG with the University of California, Davis, Alex Carner's group, and Jonathan London, when they did an implementation of ITHIM there. So we looked at what kind of code was available. We saw that no one had actually come up with a complete version in R or Shiny. So that was really, just trying to leverage what people had done before, but no one had done a complete job. So that was part of what the prior research showed, that we needed to extend the modules. We thought, and it's really CJ's contribution, major contribution to the project, says, so just step back a second, don't worry about the programming, just express this analytic engine as a series of mathematical equations, because that will disambiguate what was actually done and help us. So in part of the user's manual, you'll see these series of equations there that describe exactly what we programmed. So that was very helpful. So our process was that we also were attuned to the maintenance phase of this as well. We didn't want to create something that was so inscrutable that no one would be able to maintain it except the few programmers who created it in the first place. So we took that into account by saying, we're going to stick to the basic R program. Because it is an open source program, people develop all kinds of programs and use sometimes very sophisticated programming techniques that really are for very advanced programmers. Because we thought that the University of California or maybe some other vendor would be maintaining this into the future, that it would be a wiser bet to go simple as possible and try to program this with as little advanced programming techniques so that CARB staff and other folks could actually maintain it into the future. Okay, so there was a lot of user-suggested content. This really gets into the beyond the analytic engine back to the interface and what is wrapping around the tool itself. And again, it's to try to contextualize the health information. So a lot of comments came in of like what we should include, what we shouldn't include in the decision support on health outcomes, on air pollution, on traffic injuries, on the whole work. So we incorporated a lot of that. Part of it was thinking about trying to make it motivational in the sense of like what strategies we can use to improve health. We have a little bit of question about timing. So I will now go to, I may have to accelerate the conversation. I thought I had a little bit more time than I do. But the idea is to present the decision support information to promote increases in physical activity, increases in safety, decrease in air pollution and VMT. And then to provide evidence for that so that it's not just a bunch of assertions, that there's actually a scientific basis for that information. So the integration of this, I won't go into the details because we're a little bit short on time, but that the idea is that there are inputs, and the environment that we originally developed this in was really a desktop environment using R Studio. These are public accessible tools for a lot of folks. and to provide a mechanism that the content itself of the website, the photos, the text can be maintained by ARB staff without having to get inside the R code. So a lot of our strategy was about that, and we did implement that. The R-Shiny program then runs these inputs and then generates a web page, and that's the basic idea that we have here. So in order to run ITHIM, the user has to select a scenario, a geography, and a time period. Not a TIM period, a time period. And as I pointed out, that there are a number of built-in scenarios. The baseline is not a scenario itself, it's the scenario or the condition under which all the other scenarios are contrasted with. So whatever the physical activity distribution is at baseline, that's going to be contrasted with one of a number of scenarios. And you can see we use state agency goals as several of the built-in scenarios, the Air Resources Board, the 2017 update of the scoping plan, Caltrans Strategic Management Plan 2020, those are calling for multiples of the baseline to be increased. We also incorporated the information from the large MPOs and their most recent versions of their sustainable community strategies. I went through their EIRs and constructed what their travel patterns would be. So we looked at the health benefits of that. The U.S. Surgeon General has made recommendations for adults to have 150 minutes a week of moderate to vigorous physical activity. We also have a number of what-if scenarios. So what if you doubled or tripled, or the user can design what increment they would like to increase, as well as say, I want 15 minutes of physical activity from walking, or I want 20 minutes from biking. I mean, it allows the user to specify a specific amount of time. The other thing that's come up as a kind of scenario is recognition that a lot of car trips are really short, less than 5 miles. So that if we could only replace half of those with active transportation, we might be able to make a significant reducing greenhouse gases as well as increase our physical activity. Low carbon driving is also a scenario. It doesn't involve any change in physical activity, but obviously it would involve a big change in air pollution through reduction in tailpipe. And that low carbon driving is really a combination of electrification, hybrids, and other kinds of technologies that we envision over the next decade or two. And then the user has the option of uploading their own data if they know how to do that. As far as geographies, the 5 major MPO regions, with the exception of the San Joaquin Valley, which really isn't an MPO region itself. But in order to get stable data, I had to take the 8 counties there, with sort of using the Fresno COG data as a hub to be able to create that. But with each county within those 5 regions, you can get results that represent a downscaling of the regional rates, but adjusting for the age and gender and the burden of disease for that specific region. So it gets to the point of providing more geographic resolution. And the time periods, as I pointed out previously, they're in 5-year increments between 2010 and 2050, so that you can pick whatever time horizon you'd like to be able to do the analysis. So in the waning few minutes, I would like to actually do a demo. So for me to do that, I need to actually take the microphone and sit by my computer, and you'll be able to see this as we go through. Hold on, folks, while I get this up. Okay, I think people can see this. I think for the home audience, we'll be able to see this okay. It's a little bit bright in the room, but this is the homepage of the ITHIM website. And you can see it's still in review, but it is pretty much ready to be used. You can see there's a navigation bar. You see our word mark. But you also see our navigation bar, home, about, run ITHIM, decision support, and user support. So we use our web principles, and also this somewhat follows the design template that the Air Resources Board, their Office of Communications, has for their own website, including the 3 buttons, navigation buttons that would get you to the website, parts of the website faster. If you already were experienced and just wanted to run the model, you could just go to the 3rd button and boom, you'd go immediately there. But the taglines are there: transportation planning for health, equity, and climate change. You know, again, good design for websites is that the user should, within 5 minutes, pretty much figure out what the website is about. And if they can't do it within 5 minutes, then you haven't succeeded in communicating what your website is about. But also here, replacing short trips with walking, cycling, and transit, increasing physical activity, cuts air pollution, climate warming emissions. It's weaving together that story of what the themes are in the website. We also have a gallery of publications so that people who are interested can peruse that before they. Rest of this, right now, obviously the Air Resources Board is main sponsor of this. We are also talking to CDPH and others to help us with implementation as well. So this is our about. Next page is our about, and there's several subpages there. There's an introduction, which describes, you know, what is ITHIM. Again, it weaves together the narrative about health co-benefits of greenhouse gas mitigation strategies. It has a little bit about the history of the project over the years, how it's been used, what the use cases are, why it's important, and a number of references. So most of the pages are heavily referenced. There's some quick instructions. There's an explanation of the different scenarios. I pointed out before, these are just the verbal narrative around each of the different ways in which we can increase active transportation using state goals and plans, as well as what-if scenarios. We also have our geographies, and we list out the counties and the cities, and the regions, the counties within the regions, the time periods, and then there's a section on methods for those who are really inclined to get into the detail. There's quite a lengthy discussion here of the methods. There's also, the methods are covered in the user manual, where there's a lot of detail about the methods and references there. So the Run ITHIM tool is really the heart of the project. So I'll just scroll down and just point out, this is where you would pick your scenario, this is where you pick your geography, this is where you pick your time period. So by default, it's describing the health impacts of the Air Resources Board 2017 scoping plan. So the first, by default, you get this elevator pitch. So you get this very graphic little narrative that is just little bullet points about what the health benefits are. By changing there's a drop-down, as one would expect, there's a drop-down menu that has all the different scenarios. So if you wanted to see what the Caltrans Strategic Management Plan, it instantaneously changes all the outputs so that you can get this. And by copying and pasting and other mechanisms and downloading through the download buttons, you can actually get hard copies of this or versions of this that you can then cut and paste into your own newsletter or do other things with them. And then you can switch the time period and you'll get an instantaneous change in what the burden of disease would be, in this case, in 2035. So this is what I'll go back to the CARB plan. And this is just one of the outputs. The next output type is infographic. And it takes a second to load, but here it is. And it tells a story about should I walk, cycle, take transit, or drive? And as one scrolls down, the narrative and the case, why this is important, what the role of active transportation in improving our health and mitigating greenhouse gases is made. We're scroll down, and then this is an interactive where the scenario that you selected is on the left panel, but then you get basically the brackets of the most optimistic scenario, which is the Surgeon General, or the one that cuts greenhouse gases the most. That's the low carbon. So those are like brackets, so you can get a sense of what the impacts are. So here, I know people are probably interested in the the actual results, but you can see this scenario, which is the CARB scenario, has 15 million, has from the baseline, would actually result in 18 million metric tons less of carbon emissions. The Surgeon General would be only 15, and for the low carbon driving, you'd have a whopping 63 million metric tons less greenhouse gas emissions per year. But you can also see that there's quite a difference in the years of life lost, the health cost savings. You have to look at all the different scenarios to see, to sort of triangulate, what are your objectives and what are the strategies that would promote those objectives. So this is a interactive graphic, and again, it was really Kenji Tamari who helped program this. It was Amy Weir's design that I think is so beautiful and appealing. And it was also the Public Health Alliance Southern California that was sort of the motive force of like, get that infographic. They had tried several years earlier to do something about that. It would turn out to be very challenging. As far as tables, the way we've organized this is, again, by level of detail. So that by default, you get the summary level, so that you only would have to go to this one page to get all the travel behaviors contrasted between baseline and your scenario, as well as the health outcomes, what the change in number of deaths or and what the cost and the carbon emissions are. So if you're just interested in sort of like a quick numbers and you want to show tables, you can just go to this one page, and it has a corresponding graphs. Depending on how you want to communicate, you have a number of options. But this goes to all the way to high levels of detail, and I'll go back to tables. And it is really a high level of detail. I think it probably exceeds most users' capacity for detail. But it's available because some people might want it. So we have by high levels of detail, I mean by breaking things down by age and gender, by specific disease entities, where we have one table that you can pick which specific disease you're interested in. So if you're interested in lung diseases, you can get those tables separate from cancer or from heart disease or road traffic injuries. So it provides a lot of information. It also breaks it down by what is the health pathway. So you can get the deaths that would be attributable due to air pollution reductions versus physical activity. So that is a nice little feature as well. So as I said, lots of detail here, and this is really the heart of the tool. I'm gonna move on to decision support. And again, this is where we try to contextualize the information by providing a lot of additional information about like how big is the burden of disease. So when I get an output and it says there's 2,000 deaths averted per year, well, what does that mean? How many deaths are there in California to begin with every year? And so that people can begin to say, is this important or is this not important? So that's the whole idea, is to provide this context. We have all the different endpoints, the three major pathways. We also acknowledge that there's other pathways, and Cynthia mentioned them earlier in the morning, around noise, community severance, and a number of other ways that transportation system. We can't cover all of those in the ITHIM, but we at least acknowledge them, including also physical activity near busy roads, the questions about that, and a number of references on how that's been pretty much resolved, at least in high-income countries like the United States. I won't go through all the different pages here, but I invite folks to go look at the website. I'll show the URL, but we provide an introduction. We frame a lot of this information around what we use in public health as a PSE, changes through policy, through systems change, and through environmental change. So that's sort of a framework in which we put this information on how to change the transportation system to make it healthier. So we do this for physical activity, we do this for safety, and we do this for air pollution. The evidence page is actually recycling a lot of good work that was done by Susan Handy's group at the University of California, Davis, looking at strategies for VMT reduction, but we also tap into the Preventive Services Task Force and other sources that show how physical activity in the transportation system or changes in the built environment can promote physical activity and improve health. A lot of these strategies, there's lots of references. A week or two ago, I went through every link to make sure that it was still working. And finally, we have a user support page, which has a lot of our documentation. It has video clips. Hear me, if this is working. Hear me yet again. Hello, my name is Neil Maislish, and I'd like to welcome you to California ITHIM on behalf of the entire... I won't put you through me twice or imply that I have a split personality or so. At any rate, we have these videos which preview the website, go through the navigation so that people can feel comfortable using it. I mean, it's been designed that they can basically hack their way through it based on their prior experience with every other website they've seen. We have a quick guide to the navigation. The user's guide is roughly, I don't know, it's about 120 pages, a lot of detail. We have a chart book. So if you're really lazy and don't want to use the website, you can just click and get the PDFs of a lot of the major built-in graphs and tables. So if you're really lazy and just want to get the output there, you can do that as well. It's also broken down by California regions. So we also have instructions on how to upload the data, as well as a tutorial. It's my standard 1.5 day seminar. It's about 60 slides, so if you really want to get into the methodology of ITHIM, you're welcome to take a look at those slides and turn yourself into an ITHIM expert. The code itself is accessible, so if you want to be our shiny programmer and develop some improvements on ITHIM and are willing to share it with the larger community, you can just download the code and you're able to do that. We also have files for the equity analysis. They're equally downloadable there. We have situations where MPOs have contributed the code that they wrote that goes between their travel demand model and ITHIM, so that for MPOs, and not just in California, elsewhere, that run their own travel demand models, have the ability to tie one model to the next model to get the health benefit calculation that may not be part of their model. So we have a glossary, and that I have a few remaining slides. Let's see here that I just wanted to, so this is our demo. Point out a couple of things. Okay, that it's an important feature because I haven't seen much of this information published before around race and ethnicity in California's transportation system, and just want to offer this as something that researchers can use to explore whether state plans and goals or any kind of change to the transportation system, how it might differentially impact different race ethnic groups. Talking to folks at the California Department of Public Health that we might be able to do an income-based analysis as well. That would require some analysis of potentially confidential data, so we'll have to leave it for them to be on that. And as I pointed out, there's extensive documentation, the accessibility, and I think we have now time for questions. So
thank you so much for rushing, and I appreciate all the work you've done, Neil. And please raise your hands, and I'll bring the microphone over. And if you have any questions, also state your name. We'll start with people in the room. Anybody?
Do you need?
Thank you, Neil. I'm Will Barrett with the American Lung Association, and I don't have a question, just comment. Really do appreciate your stick-to-itiveness on this for so many years. I know we've gotten to work with you a lot on it, and I do see it as a very valuable tool that will be, as a state, as community members, as advocates, try to use this going forward to really help make the case that we do need to grow healthier as we move forward in California to meet our health goals and our air quality and climate goals. So just a note of appreciation and looking forward to being able to use the tool.
It's mutual, because without you, I mean, Will was a member of the users group, but has really promoted ITHIM over the years with various implementations around the state. So the Lung Association is a very important partner for the overall.
Any other questions or comments? Okay, I'm going to read some that we have on the website. Cornelia Aguirre mentioned, could ITHIM ever generate a result at the city level?
So let me address, I mean, I've not really delved a lot into the limitations of ITHIM, but one of the limitations now is about geographic resolution. And part of that is really about the data that are available at more refined geographies. So it depends on the city. I mean, the LA County Health Department demonstrated a way of using the ITHIM model for the city of LA. Now, the city of LA is huge. I mean, it's bigger than most counties. So there'll need to be some qualifications. What I would recommend one do, and you can, whoever the questioners can just correspond with me directly as well for how to implement it. But I would pick a region, or if the region in which the city is already located is the region that's representative, one can do some additional downscaling. You could take the daily rates, the death rates, the outcomes, and express them on a population basis. Then, knowing the age and gender composition and the size of the city, you can apply the regional rate to the characteristics of the smaller geography and get an estimate of what the health impacts would be. One obviously would need to use their judgment, because it all is predicated on how representative the city is of the region from which it's being compared to. If the city comprises a big chunk of the region, well, then it's going to make the comparison more and more valid. If it's to make a qualitative assessment that the transportation system, the land use forms, you know, the mixture of urban, suburban, and rural is really different at the regional level than it is at the city level, then one begins to wonder how valid that kind of comparison is. So that's the current approach to geographic downscaling, be above and beyond the county. So, but it can be done, and if they need assistance, I can show them how.
Thank you. Courtney also asked, will the PowerPoint presentation be posted for download? Yes, it's currently uploaded to the CARB Seminar Series webpage. If you Google it as CARB's Research Seminars, and you can put ITHIM, and it will directly direct you to the presentation. I have now another question from David Kraft, and he would like to know, how will ITHIM be used in CEQA analysis? Yeah, which I don't.
Interesting. When I've read through the environmental impact reports of MPOs who are developing their regional transportation plans, there are sections in there, mostly on safety and air pollution, but almost nothing on physical activity. So it may not be a regulatory requirement, but it is certainly educational to policymakers on what the health benefits are of active transportation. And because of the monetization, we often get very large numbers, especially using the willingness to pay method. So I think it can actually shift the discussion of the priorities of a particular of a plan. Within CEQA, I'm not quite sure, there's no regulatory requirements. So I think it's really about policy education that would be the most useful. One exception that I will make is how I have come to understand the safety components of EIR reports. Many of the subtleties that are found in ITHIM analyses, where you actually see an overall decrease in motor traffic collisions, but an increase in bicyclist and pedestrian injuries, is not a prominent feature of most of the EIRs that I read. Most of them are making statements that with decreases in car travel, there's almost an automatic decrease in pedestrian and bicycle injuries. And that is not the case. I mean, empirically, it's not the case. It is not what is happening in California, but it's also something that ITHIM actually predicts would occur until there is a very large mode share shift from cars to active transportation. So from that standpoint, I think more sophisticated approaches in the CEQA process or in the EIR process, taking the kind of modeling approach that ITHIM has used will render much more useful information for policymakers, because I think the current system is basically glossing over that possibility. They don't have a mechanism to explore that. So that's how I see maybe CEQA or EIR reports could be improved by improving the safety component of the modeling.
Great, thank you. Another question that I've received personally is a lot of people have been trying to run the model and want to know if they can input their own percentages, and I was wondering if you wouldn't mind maybe demonstrate how to use it when they want to add walking or biking, and how that is interpreted in the website.
Okay, so this is related to the do-it-yourself scenario or scenario option. So let's go back, let's see. Okay, so I'm going to go to the ITHIM tool page. Okay. Here we would pick, oops, I need to. Hey folks, we're back. So you go to the Run ITHIM page, scroll down to where the tool and the dialog boxes are. You would pick a baseline multiples. So if you're talking about a percentage increase, so this is in terms of 111 means we're at the baseline. We're not changing anything. If you want to have a 5% increase in walking, it would be 1.05. That would be how you would implement the percentage. It's a multiple of the baseline. Let's say in that same scenario, we wanted to have a 50% increase in bicycle travel, then we'd put in 1.5. Okay, so I think it's, and then say, in this particular scenario, we want to double the transit. So in that way, you're able to implement a do-it-yourself scenario. There is a subtle piece here that actually was part of prior work that was done with the California Department of Public Health, where by default, the assumption is that for every walk mile or bike mile increase, there would be a concomitant decrease in car travel. And some folks said, well, that might be a little bit too stringent a requirement. Why don't you make it less than a one-to-one substitution? So here, if you wanted to make it less than 1% let's say you only wanted to substitute, 50% of those miles, you would be able to do that. I should also point out that it's possible that given a particular land use pattern, you could actually go beyond the 100% substitution. You could actually have much higher than that you actually eliminate all kinds of car travel because retail is so close now and people take advantage of that you don't have to drive out to the suburbs to the malls there. You can just get your shopping needs much more locally. So there's a possibility of doing that as well. So I think that's pretty much there's not too much beyond that. If you want to, see it as a table, you just then click on the tab and get the results.
We have a question.
Yep. This is something that been part of the model for a while, is that you can change between miles and kilometers. You can change the time basis for active travel from a daily basis to a weekly basis. The units for distances can be per day, per week, or per year. Because a lot of people, when they think about how far they travel, if they have a car, they look at the odometer and they have a sense of, oh, I travel, whatever, 7,000 or 10,000 miles a year. So yes, there are buttons there that you can then click and get it just instantaneously recalculates all the tables and the graphs so that it's in different units. It is not a trip-based model, though. It's a distance-based model. So there is no way of immediately transferring between a trip, number of trips and distances. So that's a limitation. But these time units and kilometers and miles, yes, that's all. Why don't I just show you? I think it's easier to see it if it were just. Okay. The question that Leonard's asking is, how flexible is the model vis-a-vis changing the time units or distance units? And I'm going to go to the CARB plan because it has. Okay, and I'm going to go to a table because you'll see the changes more readily with changes here. So you can see there's a little tab. First you can select what kind of output you'd like, and then the units that are in the table. So there's measures of centrality for active travel. So that's really about the biking and walking. As I pointed out, these are log normal distributions. Sometimes people feel that if you describe it by a mean, that you're sort of overdoing it because the tail data points sort of drag up the whole value, that it might be more accurate to describe a distribution just by the median. So you can toggle between the mean and the median. So keep your eyes peeled on this because it usually happens pretty fast. But it'll be for the active travel time. Not all these tables are active travel time, but this one here is a weekly active travel time. And you see it says mean. When you click on the median, you'll see that there's changes, that it happened pretty fast. But now it says median, and these values changed. So that's one aspect of changing of units. But what the units for active travel, if you want it on a daily basis or a weekly basis. Right now, the default is weekly, but if you wanted to know on a per day, how many minutes per day. So this is the median minutes per day, and this is the baseline in California. So again, it's pretty modest, 2.5 minutes per person per day. The median is a really low level. The CARB scenario would elevate that quite a bit. Now going to the units for travel distances, we have now kilometers, and I'll have to go to a separate table where you can actually see the distances better. Maybe the medium level would be Sir. So here's the distances by mode. So right now it's in kilometers, so I switch back to miles, you get that, boom. Simultaneously, if I wanted to now do that on a daily basis, I would click the daily tab. If I wanted to do that on a weekly basis, get the weekly tab, and then on an annual basis. So it's pretty easy to switch units. It's more appealing to a larger group of users because they often think of things, in different ways. Okay. Cynthia would like me to show the cost tab. So there's the overall, let's see, I'll go to the summary table.
The greenhouse gas.
In the summary tables, you have outputs for the cost savings. This is sort of the bottom line using, again, this is the CARB scoping plan. So we're talking about, and this is being, the default year is just as if all the interventions, that quadrupling of walking and transit and the ninefold increase in cycling happened basically instantaneously at the 2010 baseline. It would result, again, using the most optimistic method, the value of a statistical life, it would result in a $42.7 billion per year monetization. That's a lot of money, folks. Even in the conservative one where it's six billion, it's a lot of money saved. As far as the carbon emissions, the scoping plan, for example, the baseline is roughly 95 million metric tons. That's the aggregate amount. It's not on a per capita basis. That's just what's coming out. And under the CARB plan, it would reduce it by about 25 million metric tons down to 77. So it's making an important contribution there for greenhouse gas reduction. Still need a lot more than that from other sources, but it makes an important contribution.
Just one more demo that I would ask before I close is if you could show how people can put their own data points as far as their...
Well, this is, I don't know if I actually have a upload.
Or where they would go.
Oh. Okay, so the last scenario on our list is a user upload. Now, this presupposes that you've read how to construct the data file because it has to have a very specific format because there's a lot of error checking that goes into this. So if you misspell the variable name at the top of the column, you'll get a notice saying, we're not going to accept this because the format is not correct. So I don't know if I have my test data file.
You may want to describe what you can upload.
Oops. Let me see. If I actually have the data file here. May not be here because I'm stop 1 second. Test data upload. Let's take a gamble that this file is actually the right one. Doubt that it is the right one because otherwise I would have gotten an error message. So now well, you can tell if you go to a table, you'll get what the upload values are. That's your feedback. If it weren't the correct file, you'd get a warning message and it would stop the program right there and advise you what field seems to be off. So you get some clue of what to do to correct the message, the error. The inputs were designed to be as minimal as possible so that MPOs and other folks could use the program, because if it took a lot of effort for them to get the inputs, they would never use it. I mean, most of the MPOs, after a 4+ year process, are totally exhausted. And the idea of them doing a health impact assessment of their plans that's super involved is not a realistic expectation, especially since they're not funded or mandated to do it. So this is an effort to make it really easy. So I'll see if I can get that file because it was in my folder. And you can see that it's a pretty pretty simple file. Um, Here is the data file. Okay. This has actually multiple scenarios. So there's blocks of 17 rows, and that's what the MPOs or whoever wants to put this in. Because we got a request from the MPOs that they often do multiple runs. So they didn't want to just like upload one set and then the next. So we've done this so that it's interactive, that once you upload all the scenarios, and you can also upload your own baseline, that then within the selection tool, you can pick whatever scenario you'd like. So you're not wedded to just one analysis. You could do multiple analysis. But I would, people who are interested in doing this should really use, look at the section in the user's guide, as well as there's a little separate piece on the user support page on how to construct the file and basically use a template that we already have and just substitute your own data and just overwrite the values. Otherwise, just leave the rest alone. So it's a pretty painless process.
Thanks, Neil. Any other questions? No? Oh, yes.
Sure.
I guess I am expecting that you cannot have, but do you do any kind of localized exposure analysis with this? And I noticed you looked at particulates, and you treat that as a health hazard too, or is it just the exercise exposure?
I think you're pointing out, an important limitation of an aggregate version of ITHIM. We've aggregated at the level of region because that's pretty much where the calibration data were available and stable. So doing geographic downscaling to roadway segments and things like that are not really possible. With this version of ITHIM, there are versions of ITHIM that are under development at the University of Cambridge that take an approach that looks very similar to what transportation modelers do. They create activity-based models. They track where people go throughout the course of their travel or their journey. And then that allows what the actual exposure to air pollutants would be as they traverse their route per day. Those kinds of models require population simulation. So those are pretty elaborate. Right now, they're pretty much for research development only. There's not been a practical version that combines the physical activity and road traffic injuries component quite yet. But James Woodcock's group at the University of Cambridge is getting close to that now. So I would say stay tuned for those kinds of models that will provide a lot of detail that are really project-oriented. That said, for example, the MTC, which is the Bay Area MPO, is using ITHIM to quantify the health benefits of system-wide projects. So but they're usually large projects. They start with $150 million of capital output or greater, and then they rank the benefits of the different projects. And traditionally, they've looked at saving travel time and some economic indicators, but now they're using it looking at physical activity, air pollution, and safety, and it's just switching around their priorities altogether. I mean, point out the last time I plugged into their process, they have bubble diagrams and all kinds of things for each project, and it says how many lives are saved for which health pathway, and it elevates mostly large regional transportation projects rather than like widening existing roadways. They tend not to have the health benefits. So from that standpoint, it can be used, it is being used in their travel demand model, but it is one project that's having system-wide impacts, and that is how they're using the model right now. So that's useful. But the kind of geographic downscaling, you're just going to have to wait for more advanced versions of ITHIM to be able to do that.
Well, you suggested as well that particulates are an issue. Are there other pollutants that we should be worried about aside from greenhouse gases and particulates?
Well, we know that there's somewhat of an underestimate going on in the model, because besides PM 2.5, I mean, there's PM2, there's diesel PM, there's PM10, there's NOx, I mean, there's ozone, there's a number of other pollutants that add to the burden of disease that are not included in the model. So from that standpoint, yes, we know that this is an underestimate, that if we added these other endpoints, there would be a higher burden of disease. But what we did is we picked the one endpoint, PM 2.5, that most people have, there's strong evidence for. There's very little controversy about whether that impacts human health or not. So that was the starting point. But you're right, we could be adding more endpoints to make it more accurate.
Anybody else? No? I'll check one more time, and it seems like we're no more questions, and I want to thank everybody for hanging as long. This is a very valuable tool, and I hope everybody gets to use it. And I thank Neil especially for his dedication. Thank you all. Bye.
Thank you. Yeah. Oh,
Sorry.